And we're going to do this. Okay, here we go. Got our thinking caps on?
Ready.
All right, we're ready. I'm ready. Like I was saying, are you ready, Freddie? I'm ready. Oh, I was looking. Okay, let me go back here. You can tell I was doing my homework. All right. So today is, again, it's week 6, folks, and you just see that I did put your homeworks on the grade book. It'll be on there for 2 weeks to show you what your homework grades do to your KGAs. Okay, so it gives you an idea. All right, here we go. Chapter 9, the family after birth. Like I said before, this is called the purpurium, and that's an old term, but they still use it. It's known as the postpartum period. It's also, let me tell you, it's also sometimes referred to as the 4th trimester of pregnancy. 4th trimester. It's very important, this period, because now she's going to go through the process of involution. And it's important time too for both mom and baby and daddy. And I tell you, there's siblings at home, the siblings, everything. And again, certain cultures are, they handle the postpartum period a little bit different. The Asian culture, for instance, that I experienced a long time ago, but I was a new nurse, was they don't drink anything cold. Okay, they have that they like everything warm. So I was trying to get my new delivery to drink water. Yeah, and I was bringing the pitcher in, and I made sure that, okay, here's your water, here's your glass, I got it in before you, and let's get this fluid in, because she was breastfeeding, and the more water that you take in, it makes more milk. Okay, well, she never drank the water. So I was like, oh my goodness, what am I doing wrong? So her husband finally came in, and she must have said something to him. And he says, nurse, are you trying to get my wife to drink this cold water? And I said, yes, I am. And I went through all the spiel of why I wanted her to drink water. And he says, it needs to be warm water. She won't drink anything cold. That's our culture. So I said, oh, it got me again. You got to be really, really, really up on your culture sensitivity, and we have so many different we have such a diverse population in the hospital today. And I share that story because it did happen, and I didn't feel too good afterwards. I thought, I should have realized. So, next time you can realize that too. All right, then we have certain groups. Well, there were certain groups we worried about when they were newly pregnant. Same thing is now when they have delivered, because the adolescents, when you have an adolescent teenage mom, she's got to learn how to do what? Be a parent. Okay. They need a lot of support. Single women, they need to have support, and a lot of them may not have anybody. Okay. And here they may want to breastfeed, but in 6 weeks they have to go back to work. Okay, because they have to support themselves. So it's hard to be a single mom. It's hard to be an adolescent, teenage pregnant mommy. Families that are at or below the poverty level, they need financial support. So now, what kind of a person in the hospital am I thinking about with all these different specific groups that need help? Who would you be?
Caseworker.
Yeah, referral. Sure. Yeah. Even before they leave the hospital, I want to make sure that the caseworker gets in there and starts working with them. How about families that have twins or triplets? Okay, they may be facing a whole bunch of different challenges, such as having babies in the NICU, the neonatal ICU. They may have had a baby who went into preterm labor. She went into preterm labor. Now she's got babies that are preterm birth. Okay. They actually too, because they're preterm, a lot of times those babies are taken to the NICU very quickly, so that we can start working on them. Is that mom doesn't have that bonding. Okay. And so there may be a delay in that bonding. We get them in as soon as we can, but it's all according to what the babies are, how they're doing. You might have patients that, you need an interpreter. All right. Do you use the nurse on the that's working with you as an interpreter?
No.
No. And that's always a good test question, and a good HESI question is use an interpreter wherever is appropriate. That if you can communicate with that patient, whatever you say, if they can't understand, it's useless, right? So you get an interpreter. Well, you got that blue phone in the hospital. We used to use that a lot. And that phone is it's just unbelievable. And you have every language in the entire world, and it's amazing. And at least you know that these people are understanding, what you're saying, and then they interpret it to the patient. It works out good. Okay. All righty. So again, always an interpreter, never a family member. And that's always usually a test question or a HESI question. Okay. All right. So let's go through the changes that are really important and these occur in mom. All right. So immediately, guys, after delivery, the mother experiences multiple physiological changes. Okay. And it's important for the nurse to always assess all body systems and not just focus on the reproductive system changes. But right now, we're going to look at the reproductive system changes. So here it is. Now, what I did on this slide, it's got a lot of good information, but I did highlight things I really want you to take note to. So on the uterus. Okay, remember, it took 9 months to get that uterus to be pretty big, right? Okay. Now, after delivery, baby comes out, placenta comes out, a lot of fluid comes out, and now the uterus is going to go through the process of involution. Okay, and that's where involutes, the uterus actually goes back down, shrinks back to its pre-pregnancy size. Now, it takes a while. It's usually 1 centimeter per day of that involution process. And I'll tell you that breastfeeding makes it go faster. That's why I think I told you the other day, that's how I get my moms to breastfeed, is 500 calories more they can have in their diet. And the uterus shrinks more because you're producing now even more oxytocin for that uterus to go down. So if somebody wants to be in their skinny jeans faster, that's how I usually get them. And they go, okay, I'll breastfeed. And I go, good. Because not only now mom benefits, but baby benefits because baby gets the antibodies. Okay, so I did put on there, and then everything in the uterine lining, the decidua, it's called, remember the decidua? That's the uterine lining. That gets all, shed. It all comes out. The main thing is we must make sure that the fundus of the uterus, which is the top portion of the uterus, is firm. That is so important. So we're going to be checking. Now write that down. Fundal checks. Very important during postpartum. I'm thinking back in the pioneer days when a lot of women died after childbirth because they hemorrhaged. That's because probably nobody knew about massaging the uterus back then. All right. But we massage it very much so. And we want that top of the uterus, which is the fundus, to be firm. Now, when you're doing it, you see my hand, and I have my hand cupped. And what I do is I take my other hand and I put it on the bottom of her uterus, on her abdomen. I can feel it. And I'm going to massage. You see what I'm doing? I'm massaging. If you ever made bread, it's like kneading bread. Okay, so next time you knead bread, you can think about this. And what you're doing is you can feel that top portion of the uterus is nice and firm. Okay, and then her afterbirth pains. Now these are pretty painful. I had a patient that told me these pains are worse than my labor pains. Well, that's because right now I'm giving you IV Pitocin through the IV, and then you're breastfeeding, so you're releasing your own oxytocin, and oxytocin is a prostaglandin which makes your uterus contract. Okay, So there it is. It's pretty painful. And then lochia. Now it's highlighted, and all these are in red for a reason. So lochia. So lochia rubra is the first couple days, guys. Is red bleeding. Okay, red bleeding. And then it goes into lochia serosa. So that's usually from like day 4 for 2 weeks. And then it goes into like lochia alba. And alba is a mucousy white discharge. Now it's really important on your discharge planning that you would teach her about this, because she's going to go home and she's going to be probably, if you discharge her in 48 hours, she's still going to have the rubra. Okay. But then, then it should, after that, it should start to get a little bit more pinkish. Okay. And it has some more, like, it has some blood in it, but it also has mucus. And then it goes down to alba. But now she gets down to, say, she's about a couple weeks out, maybe say she's 3 weeks out from delivery. Okay. And all of a sudden she gets up and she's got a whole bunch of blood around her. That's not good. That's a bad sign, because she shouldn't be rubra anymore, right? She should be more serosa going into alba. Should be getting lighter. Okay, so that means that she has something there that she's bleeding. All right, so what do you have to make sure that she understands that when she sees that, she doesn't say, oh, it's just really red again. No, she calls the hospital. She calls the clinic. She calls the hospital. She'll go back to the hospital through the ER, and they will assess her. Now, I'll tell you what the culprit is on that is usually retained placenta fragment. It's up there. Her fundus is not firm, and she's bleeding again. All right. It's because the body knows that shouldn't be there. So it's trying to get rid of it itself, and it can't. So she goes back to this heavy bleeding. And so here you go. She's going to have DNC to clean out that uterus. So that's important. You'll probably see that again. And I know Hesse likes that kind of question. Okay. All right. And then the cervix, it will go back. It does shrink back, but like it never goes back to what it was pre-pregnancy. Okay. It's been stretched. So, and every time you have a baby, it gets pulled a little bit more wider and wider. That's why when you have like a Gravida 6, Para 5, having her baby, she can dilate very quickly because her cervix is so thin. Okay. All right. And then you got your vagina. And usually the rugae, or we call it rugae, is the vaginal folds. They usually make its way back, usually about after 3 weeks postpartum. All right. Now we try to tell moms not to have sexual intercourse for at least 6 weeks. And then usually the husband gives me a dirty look, but that's okay. It's because I want her to heal. Okay, want her to heal. And I don't want any bacteria getting up into the uterus. And so we try to tell them that the postpartum period, please, is a time of healing. And let's just wait for a little longer. At least give 6 weeks. All right. And then our breasts. The breasts, well, we have nursing care we're going to talk about, and engorgement. That is a topic to please take note to also. Okay. And if you ever had a baby and you didn't breastfeed and you got engorged, I tell you, engorgement is painful. Very, very painful. All right. So we talk about the perineum. When we talk about the perineum, we are looking at the episiotomy. The episiotomy. I did send you out the RETA, which means that's your assessment of your episiotomy. This is when you work postpartum. And I'm going to tell you, they do hire LPNs for postpartum, for mother baby units. And so you have the episiotomy that you got to look at every shift. So I'm looking at the episiotomy for redness, because redness means what? Infection.
Infection.
Edema. After they deliver, been pushing for 2 hours, their perineum is swollen. It really is. And it's got ecchymosis. Ecchymosis is a term for bruising. And so it is. And then if they had an episiotomy, guys, they've had stitches. So I look for approximation. Now let me explain to you what approximation is when you have, say, here's the sutures. Okay, so I bring the skin together, the perineum together to suture it up. Now, sometimes the sutures can give, and like, see how my little hands showing you? Okay, and sometimes you get little gaps. That's how you have to chart the appearance of the episiotomy, is how much is that, does that skin approximating to the other skin. All right, because we want a nice incision, because she's gonna live after this baby. All right, and she's gonna have sexual intercourse after this baby, and if this is not sewn up correctly, it can affect her for the rest of her life. So how are you going to take care of this episiotomy that's got bruising and is swollen, and right now it's a little red? Okay, and the sutures look pretty, they look pretty tight right now because she just came out from the labor unit. You're going to put ice packs. Write that down. Ice pack to the perineum for the first 24 hours. That's usually ends up being a test question, the first 24 hours. All right, and it works. And then after 24 hours, you can do your cis bath. And your cis bath are nice. You know, you sit on the toilet and you have like this tube, and it connects to the faucet, and you let the warm water just run over. Women love it. Okay, they're usually in the bathroom for a while because they just take that cis bath every time they go to the bathroom, or they just go in there because it gives them relief. But ice pack for the first 24 hours. Then after that is the cis bath with some nice warm water. Okay, and then some women have to have pain medicine. Okay, all right. And remember, ovulation administration will start all over again. So we want them to make sure that they're on birth control when they start having sexual intercourse. Because I've had women that were breastfeeding and they weren't on birth control and had sex and got pregnant and were having another baby before the baby was even 2 months old. That kind of makes it hard for the whole family. All righty. So here's our first brain teaser. So which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum?
Ice packs.
D.
All right. Okay. Exactly. Okay, the breasts. All right. So we're going to, as postpartum nurses, we're going to assess the breasts. Now, the first 2 to 3 days postpartum, the breasts are full, but they're soft. Okay, it's just they're soft. But then on day three, the milk comes in, and moms will even say, "Oh, I think my milk came in." Okay, because then they can feel that they're more firmer and they're a little lumpier, because why? They have more blood flow. All right, there's more blood flowing and there's milk production. That's good though. Get that baby to breast. Now, you can have engorged breasts either if you're breastfeeding or you're not breastfeeding. It's just that when you breastfeed and you're feeding these babies, you got to make sure that they're emptying the breasts. Okay. All right. Now, here's pretty important. It's in red. Nipples are assessed for redness and cracking and washed with only plain water. You don't need any fancy things on the breast. You don't need any fancy creams on the breast. And usually I tell mom afterwards, after they wash their breasts with water, just let it all kind of air dry. Okay. And that's the best way. Okay. And they usually can do that.
Does putting the breast milk around your nipple, like rubbing the breast milk in, does it help at all?
Yeah, you can do
It does
that.
help. It helped my daughter.
Yeah, you can do that too. But no fancy like creams like lanolin or anything like that. No, not at all. Plain water to wash. And then if you want to, it does feel good to take some of the breast milk and just put it around the nipples. All right. The main thing is support bras need to be worn. All right. Because the breasts are going to get heavy. And it takes a little time, but wear a good support bra. Okay, now we're going to go from the breast to the cardiovascular system. So note that after delivery, her pulse could be slower. So she could have bradycardia. Don't forget, they lose a lot of blood in a delivery. All right. But remember we had that increased blood volume in pregnancy, like 45%. Well, that's what it kind of accommodates now for at the end here, after she delivers, is that she doesn't get, I mean, totally anemic down to nothing when after she delivers, because she's had an excess. All right, and coagulation, I put in here in yellow. The blood clotting is usually increased. It does increase during pregnancy, as we studied, and remains that way for 6 weeks. What happens during that time, though, your patient is prone to blood clots. And a lot of times we've had women that had pain in their calves. And so they call the nurse down and you want to assess for a blood clot, a DVT in that leg. Now, if she has tachypnea or dyspnea, which is rapid and difficulty breathing, you need to get that checked right away. Because a DVT in the leg can break loose. They cause pain and they break loose and they can travel very quickly up into the pulmonary artery. And that's when she becomes dyspnea. All right, and then you got blood volumes. You got, you're going to get remember we got the blood CBC on admission to L&D, where we're going to get another H&H CBC when she gets to postpartum. I got to see how much of a difference now she has. And then you have a low H&H and you have an increased WBC. Why do you think we have an increase in WBCs?
More about blood volume.
Well, WBC is what? It's white
blood cells.
And that usually is an indication of what? The body's working hard to get rid of an infection, right? Mm-hmm. So what happens that the body during labor is so taxing. Labor is taxing to the woman's body that she increases her WBCs during the labor process. So that's why you might see that WBC on postpartum. Now it will go down and it will level off back to normal. Okay, but that's to be expected because she's had a rough labor and delivery, and birth and delivery, or labor and delivery. Okay, and then you have chills and you have tremors. Okay, and then you might have some orthostatic hypotension, and that's where you have to be very careful when you're getting her out of bed for the first time after delivery. Now I'm going to tell you, I work postpartum also, and when I got a lady out of bed after delivery, I made sure her blood pressure was pretty stable, and then she wanted to go to the bathroom. Well, I let my partner, my other nurse colleague, to know, I'm getting Mrs. Jones out of bed. I may need some help. Just be on alert, okay? And so that's what we do for each other, because when you get a person out of bed for the first time after having a tremendous blood loss, what do you think is going to happen? She's going to feel what? Lightheaded, dizzy, yeah. And so usually a lot of times they can go down on you and very quickly. So after I make sure that she's stable enough to get up, I take her, I get her up, I have her sit up first. I do a slow process here. I have her sit up, she dangle her legs, she looks at me, I look at her eyes, I smile, I ask her some questions, she answers me appropriately, and then now we're going to get up out of bed. I get the chucks, We take the chucks with us because when they first get out of bed, they're gonna have a loss of a lot of blood. Okay, whatever's been laying up in that uterus is now what? Gonna come down. Gravity is
Yeah.
gonna pull it down. Okay, and so and it's kind of a weird feeling. Ooh, and I go, you're fine. And she's breathing okay. Everything's good. She's talking to me. And I always had this little chair, and we have these little chairs in the room. And I just kind of always push that chair with me, dragged it with my foot. It's a scene to be seen, to see. But you know what? It was good because if she did go down, guess what? I had that chair right there. Yeah. And so it's that's kind of my little secret is that I never had a patient laying on the floor. All right. Yeah. Because when they go on the floor, it's hard, and I don't want them to hit their head. No, because X-ray, they have to send to X-ray and everything. So you want to make sure that you're proactive and thinking all the time ahead. Okay. What constitutes a hemorrhage for vaginal delivery? If you have 500 mLs or greater, a loss of 500 mLs or greater, you have a hemorrhage. If you have a loss of 1,000 mLs or greater, that's a hemorrhage for a C-section. Okay. And hemorrhages, a hemorrhage is our code blue. It's equated to a code blue that on the med-surg floor. Okay. And we treat it as such. And I'm gonna I have a great video on a simulation of a postpartum hemorrhage, and I usually show that in my class. So I'll send that to you under announcements. Okay, and really watch it. It gives you a lot of good clues. And maybe if do you have sim on class on your campuses? Hopefully you'll have that opportunity to kind of do that too. Okay. All right. So again, remember I told you she usually has bradycardia after delivery. Okay. Now, I just said this, pulse is usually as low as 50 to 60 beats per minute. And it's only lasts, guys, only about 48 hours after birth. Now, I know a HESI question is, she had a delivery and, you're thinking, okay, the pulse has got to be, slow, bradycardia. And it says something, if she had tachycardia, would that be a normal finding? No. If she had tachycardia after delivery, what are you thinking about?
Hemorrhaging?
Yes. Hemorrhaging and what? I think somebody said it. Shock.
Shock.
Because tachycardia is your first actual sign that your patient is going into shock, right? So what are you going to do? Okay, now that we're thinking, now what's the next thing I'm going to check real quick. Why is she bleeding, right? Why is she bleeding? So what am I going to check?
Either her vagina or the
Asian or the
uterus,
The
the fundus.
uterus.
The fundus, yes. That means that, she's bleeding a lot related to a boggy uterus. Okay, so I'm going to be checking the fundus. Now, what else am I going to check too? What else could cause her to bleed like that? That's another reason.
The
Have
placenta,
a laceration.
or she could
Okay.
have a retained placenta.
I'll come back to that laceration. But what I'm thinking is bladder. Check the bladder. Okay, if she's got a full bladder, that's going to push that uterus up, right? And displace it over to the side. And so therefore, empty the bladder. And when you empty the bladder, you can see the uterus. You can actually see this. The uterus actually comes back to midline where it should be, and at the level of the umbilicus. Now, let me tell you, right after delivery, that uterus is midline at the umbilicus. And remember, every day it goes down at least a centimeter, at least. Okay, it could be more, but it could be at least a centimeter. Now, usually that's a great test question. And read the question. It may be 3 days that you have this lady's postpartum of 3 days, where would her uterus be?
After where? 10 days, you said?
Midline,
She'd be midline, right? And she'd be 3 days postpartum. So if I'm going down
1 centimeter.
1 centimeter, which is like
Under-
every day,
Should be under the umbilicus?
it would.
That's what
It'd
it's
be
showing in the
what?
book.
It'd be 3
Yep.
centimeters, right? 3
Mhm.
centimeters below the umbilicus. Okay, did I lose you there? Okay, so if the question says a woman who is 3 days postpartum, where would her uterus be? That
3
would be what?
centimeters below the
Three.
umbilicus.
3 centimeters below the umbilicus, right? And so now I'm going to ask you another question. Are you ready? What kind of lochia do you think she would have on 3 days?
Pinkish?
Oh,
Maybe
yeah,
like the pink
serosa.
one.
I think
The
I hear
lochia,
it's
yeah.
a pink one, serosa. Yes.
Yeah.
Okay. Very, very good. Okay. I'm proud of you. That's great. Okay. So remember that. You'll see it again. Okay. All right. Now, to reestablish normal fluid balance, right? The body gets itself rid of like excess fluid, right? Got to get rid of it. So she either is going to sweat it out or what? She's going to diurese. And that's what happens too. The body is very smart. The body knows how to get rid of stuff. All right. On the hematocrit, don't forget, she's probably, you got a lot of fluid, remember, and the fluid is shifting in the body. So, and remember, fluid can dilute blood cells. So by the time she gets through like 8 weeks postpartum, her hematocrit should be back to normal. All right. A lot of times what we tell them after delivery is take your vitamins, because we know that doesn't matter. Everybody's going to lose what? Blood after you deliver. During delivery, after delivery, and going home, she's got some more. So yes. So we usually tell them to take their vitamins. White blood cell counts, I remember I told you, are usually elevated, and it does return back to normal by 12 days postpartum. So the body goes through this is an exchange, this is an extreme change to the body. Okay, and remember, she had a stress of labor, and so her WBC count went up. And they can go up as high as 12,000 to 20,000, which at that level you're thinking, oh, infection. But it's normal. So what happens too is that she can drink the water, she can flush her system, and it's good overall. It's good for breastfeeding, it's good for mom, it's good for diuresing, it's good to get the fluid out. Okay. Remember, fluid in equals fluid out. Okay, so here's your nursing care, and this is during the 4th stage of labor. I'm going to take her vital signs. Okay. She's on the floor. You are working mother-baby units. So you're doing the vital signs every 4 hours for the first 24 hours. Okay. And temperature, it can rise. It might go to 100.4 for the first 24 hours, but that's why we're pushing fluids. Remember I told you I was telling that poor little Asian patient of mine, drink your fluids. You got to get this fluid in, because I'm thinking I got to flush all this stuff out, make sure her temperature doesn't go up. If she drinks the water, we'll be in good shape, right? Good for breastfeeding, I'm thinking also, except she wanted warm water. Okay, and your pulse. Pulse, remember, is usually normal, and it's very normal to have bradycardia. Remember I told you that? So if you have a patient that has like a high, she's running high, maybe tachycardic, not good. All right. Okay. And you always check for edema. We talk about edema, especially in the lower extremities. All right. But above the waist, let me tell you, above the waist is never good. Because what? We're expecting it to be a edematous in the lower, because that's where the fluid is shifting in the body to the dependent area. But above the waist, around the belly, the cardia, it's your heart, right? So that's never good. We don't want that, because that could be, now she could be going into pregnancy-induced hypertension. All right, and we check the legs for what? What did I talk about before?
Blood spots.
Blood clots, yes, blood clots. And it's called the Holman sign. If when you dorsiflex her foot and now her calf, when you do that with your foot, you put pressure on your calf. And when you do, and when she has she goes, oh, that's painful. That's a positive Holman sign. Well, then you have to call the physician and you have to get an order for a venous Doppler, and we have to rule out the DVT. We just can't say, oh, you'll be okay, because we don't know she's going to be okay. So we have to make sure that we do the right thing. Okay.
Ms. Dunham, I had a question.
Sure.
It was about something you already went over about massaging the fundus
Mhm.
when it's supposed to go back. It said in the book that there was a time where we're not supposed to, like if you feel it, you don't need to or something. I'm
Well,
not sure with that.
I tell you, if you're working postpartum, then you always want to make sure that you're going to check. Now, even C-sections we check, because I have to make sure that the fundus is firm so she doesn't hemorrhage, because it can change. She could be, I'm going to tell you something. She could be firm 1 minute, and you go back, and then she says, oh, I feel really wet. And when they say that, they said, I must have gone to the bathroom. I said, on myself. And you look, and you got blood. So what am I going to do? I'm going to check. Now, if you're thinking maybe, well, okay, I checked the fundus, but she's having bleeding. What I'm thinking, she could have a laceration. So a laceration is different. A laceration is a trickle of blood. And so what it is how you have a water faucet, and the water faucet goes to, like, trickles the water, okay? And if you don't do anything about it, what happens? You get a sink full of water. All right, same thing. She could have a high laceration. You can't see it. Her fundus is okay, but she has this bleeding. So what you're going to do? Well, you can't do anything. You have to call your physician, and he's going to come in, or the midwife, and she's going to put a sterile speculum in, and they're going to look to see if it's a laceration, and then that's got to be taken care of. So that's another type of bleeding after delivery that could cause a problem. So write that down, guys, because you're probably, I know it's usually on an exam about laceration. It's a trickle of blood. Okay, we already talked about orthostatic hypertension. Blood pressure falls when either she gets up or stands, and she might feel dizzy or lightheaded. We talked about that already. Remember, the first time getting out of bed is one of your worst times. And I tell you why, we always tell the patient, call me, please, when you get out of bed. Now, a lot of times patients sometimes they don't want to do it because they don't want to bother the nurse. They see you running around and they say, I don't want to bother the nurse. She's busy enough. And I said, no bother whatsoever. You call me when you need to get up, go to the bathroom. Now, why would I say all that?
Safety.
To ensure she don't try to get out of bed on her own.
Yeah.
Cause an accident.
Yeah. And then she has a fall or something. So again, am I thinking ahead?
Yeah.
Yeah. Are you critically thinking? Yeah, I am thinking ahead. Okay. How about the kidneys? Well, the kidneys do return back to normal within a month after birth. Okay. So again, what I want you to remember is a full bladder can displace the uterus and lead to postpartum hemorrhage. We talked about this. So it's very important to keep that bladder empty. And then if she's a woman that she is peeing, but she's going more frequently, but small amounts, she could have what we call residual urine. She's not emptying properly. That's a problem. And I would do a urinalysis on her urine to find out if she's got an infection there. There's a reason why she's not. And a lot of times, if you have a Foley in too long, that makes that bladder very, very what? Lazy. And so that causes another problem. That's why we get those Foleys out very quickly after delivery. Okay, yes, because residual of urine can cause a problem, cause infection. Okay, so that was the kidneys. Make sure they're working. GI system. A big problem, again, is what? Constipation. Okay, so remember the diet for constipation. I'm going to give her high fiber, lots of water. There's our water again. Water is so necessary to the human body. And then two, the medications that we're giving her. Maybe if we're giving her some pain medicines, that slows the peristalsis way down. They can get constipated. Her abdominal muscles, they've been stretched out, so they're kind of weak. The rectus abdominis rectus, right through the middle, right? Those abdominal rectus, those muscles have been stretched. It takes a little time for those to come back. Hemorrhoids. Hemorrhoids. They are very sore, and they very much get very blossom during the pushing stage. Very much so. And if she pushes for a long time, the hemorrhoids that maybe were small, but now they have blossomed into what? Big cauliflower. They are painful, folks. And so what I want to do, I don't want her to have hemorrhoids, right? But if she has hemorrhoids, ice pack will be very good too. And then you want to alleviate the problem. I'm going to encourage her to have a high fiber diet, increase fluid, and get her walking. And if she's got some hemorrhoids, she's going to be going out, but she's got to get walking, because that will help her handle the constipation. We'll give her stool softener. Yeah, we'll give her some Colace. Give her stool softener so that, because I'm going to tell you something from my experiences, that a lot of women are scared to have that first bowel movement. And I keep telling them, I got to make sure that everything comes out good. You got to have it here, so it doesn't. We know what to do. I don't want you going home and being constipated, and then not have a bowel, or go home and be in grit. I rather see what's going on here. I can take care of it. We give them Epiphone, Dermaplast. These are all topicals that you can put on. Again, every time the patient goes to the bathroom, she's going to perform pericare. Okay, warm water in a bottle. So she urinates, then she's going to do a peri bottle, warm water, and just squirt all around. And she's cleaning everything off, and meanwhile it feels good. Never wipe. She's going to pat dry. And we want to make sure she never goes from the back to the front, right? No. Go from the front to the back, okay, and throw it away. Don't reuse it. Just pat, put in the garbage, okay? We got to keep the episiotomy very clean. You don't want a patient to have episiotomy and to get infection. No, those are very ugly looking infections, by the way. Okay, the integumentary, or the skin, we had during pregnancy, we had the hyperpigmentation. Means a lot of changes, like dark, right? Like, remember the linea negra? Well, that dark line that goes up the middle of the right in the middle of the belly. Well, that's going to disappear. Hey, the chloasma, which is what? The mask of pregnancy. Okay, that disappears. Now the straight A gravidarum, those little stretch marks, they're there for life. Okay, and as the patient gets into her 60s and higher, they kind of fade into like a silver. Okay. Now the musculoskeletal system. Oh, didn't you have a hard time with this, right? The abdominal muscles, there's your dectus erectus muscle. Remember I told you that going through right through the middle. That all takes time to come back. It takes about 6 to 8 weeks. And you have hypomotility, mobility, excuse me, of the joints. Okay. And all has to stabilize within 6 weeks. You notice the 6 week pattern? You hear it?
Yeah.
6 weeks, 8 weeks, 6 weeks. Yeah, postpartum. That's why we say, please give your body some time to come back. Okay, go back down to pre-pregnancy. When you have a good postpartum period, the body can do it and you'll feel better for many, many years to come.
What
And
about after a C-section? For
Yeah,
those muscles like
C-section.
that, when they cut them open?
Yeah, C-section, if they have a low bikini cut, they do very, very well. It's the same involution, and it's the same, make sure the bundus is firm, the bleeding. They have a little, sometimes they have a little less bleeding because when you do a C-section, we suction all that blood up, you know, we have a nice clean abdomen when we close. But, you know, it takes time. Same thing, all the body, you know, whatever dominant muscles were enlarged during pregnancy have to go
Mhm.
back.
Okay.
Kidneys have to be functioning, your GI system. And with C-section, you've probably given them some strong drugs for a day, and that can slow down the peristalsis in the GI, and they get constipated. So I'm going to get them on a little stool softener. I'm going to get them drinking water. I'm going to get them out of bed, get that Foley out and get out of bed. Now, granted, when they get out of bed for the first time, they're going to be sore. That's why the low bikini cut is really nice, because they don't go through as much muscles as you would do if you had a classical incision. And, you know, in any surgery, you always want to brace the incision when getting out of bed. That means get the little pillow and tell them to press right against where, you know, when they're getting up, push that, support that incision. Take a deep breath, get up, hold it, and now you're up. And breathe. Hold the belly, hold your pillow, and now we're going to transfer over to the chair. Got you out of the chair, got you out of bed and into chair. And that helps prevent blood clots also. Okay. For an exercises for adjunct vaginal delivery, even C-section, but you know, you're home now. You could do some Kegel exercises. Now, the Kegel exercises it tightens the muscle of the perineal area. So you tighten and release, tighten and release. Now, remember this. This helps to strengthen the muscles that are involved in urination. Remember that. This helps strengthen the muscles involved in urination. You will see that again. Okay. Now, after about 5 weeks, you could do some abdominal muscle tightening. A lot of ladies, you know, especially our young ones, they're already trying to get their shape back. So they're already doing some of those nasty old crunches. Okay, pelvic tilt, head tilt. When you have a C-section, those are a little harder to do, but the Kegels you can do. Kegels you can do, and it helps strengthen the muscles involved in urination. I tell you, all women should be doing Kegels, because, you know, right now you're doing great, but when you get in your 60s and 70s, 80s, 90s, those get very weak, and you start to have urination. But you do Kegels, you won't have that problem. All right. Okay. So the brain teaser, you ready? All right, here it is. Which information will the nurse include when discussing Kegel exercises with a postpartum client?
A.
Very good. Now, would you do Kegels if your bladder is full?
Oh,
No.
No. Okay, good. It is. It helps strengthen the muscles involved in urination. I told you you're going to see that again, and you'll see it again. Okay. The immune system. I tell you, every part of this poor lady's body, right? If you had a baby, you know, you've been through it. But anyway, you want to prevent blood incompatibilities. Okay, so if she's Rh negative and baby's Rh positive, what are you going to give mom?
Rogan.
Rogan.
Rogam. Okay, and Rogam is given 72 hours after birth before she goes home. Rogam. And what you're doing is that you're helping what? The next pregnancy. All right, so you want to make sure, because sometimes, you know, a mixture can happen, and if it does, you want to make sure that you protect these babies. All right. Rubella. Remember, we don't ever give rubella during pregnancy. So now this lady has delivered, right? She's delivered. And you know that she needs the immunization of rubella. So you can give it to her after delivery, folks, after delivery on the postpartum floor. And she can breastfeed. She can breastfeed. And she has to wait at least a month before she gets pregnant again. And yes, you're gonna say, well, she just had a baby. Oh, you gotta put that in there, because you'd be surprised. They're back at the clinic before you know it. So yes. So rubella, if you know, and you can usually run a titer on them, and she comes up as not immune, you can give rubella after delivery. Now, and then of course, as I said, she can breastfeed. Okay, everybody got that? And she has to wait a whole month before she gets pregnant. All right. So now here is your nursing care following cesarean birth. Now I think Jessica saw a really good experience the other day at her clinical. She saw a cesarean, and her patient. You mind if I tell them your patient was breech? Okay, her baby was breech, so she could see a cesarean that day because of breech. Okay, that's one of the indications. So and I tell you, thank goodness she had a C-section, because it ended up being a macrosomic baby. Okay. All right. And you just never know. You never know. All right. So your nursing care is the same as normal vaginal delivery, except that little word, except. Okay. So you want monitoring of your abdominal dressing. You got to look at the dressing. And I'm going to tell you what a little tidbit is. If you're looking at dressing and you see a little seepage on the dressing, you take a pencil, pen, and all you do is put a little circle around that. Then as you take care of them and you're looking at that dressing again, and I see now there was bleeding that has now extended outside of my circle. That means there's bleeding occurring, right? So I'm going to report that. And we don't usually take off the dressing unless you get the doctor gives you an order that you can remove it. It's because the surgeon always likes to remove his first bandage. And that's normal. They like to see their honest what they've done. So then you just call the doctor and he'll say, okay, either you can take it off, Irene, or I'll come in and I want to see it. All right. So you're always looking at the abdominal dressing. And I'm looking at the abdominal dressing. I'm also looking at what? My fundus. Okay. Now you have to just gently, though. I'm not going to use the same kind of kneading. Remember I told you about the vaginal delivery? I'm not going to use the same one. I'm going to just check. Okay. And I can check with my 2 fingers. I don't even have to use my whole hand. I just want to make sure that I can feel it. I feel the fundus is firm. We're A-okay. So I'm going to do a fundal assessment. Lochia, like I said before, Lochia is generally a little less because we do a lot of suctioning after we take that baby out. And then we have a urinary catheter. We have to monitor. We have to watch the urine output, and we have to watch the color. Now, in the beginning, what kind of color you think would have if I was assessing her right after a C-section?
Did you say what color?
Yep. What
Would be
color?
bright red.
Like Loki or rose, yeah? Like the
Yeah.
real red, red?
it would have in the urine itself, it would have some what, blood, right? You see a little, we call that hematuria, and we would see that little bit of blood. Mhm. And after I do my recovery, before I send her out to the mother baby unit, what I'll do is I would empty it. I always like to empty my Foley's before I take my patient transfer. And then when I take her out to the floor, then that gives that nurse, now she can really see if the hematuria is continuing or it's going to be, you can see the dilution happening. Okay. And then respiratory care. She had a C-section. You have to make sure that you're assessing lung sounds and you're assessing what respiratory rate. I don't want tachypnea. So I want to make sure my respiratory, and then and my lung sounds. Okay. All right. And then if she had a general, it would be very important to what? Cough and deep breathe. Okay. If she had a general, you have, because remember, whatever is in there has to come out. And then I want to prevent thrombophlebitis, because remember, increased coagulation during pregnancy. Okay. And then pain management. C-sections, they are more painful. Okay. And they have to be handled. And so we do some pain management. And especially too, that's why a lot of breastfeeding patients with C-sections don't like to breastfeed, because they have more of what? Afterbirth pains. And on top of that, then they have the C-section and oh, they're in pain and they don't want to really breastfeed. Okay, here's a brain teaser. All righty, heads up. Which will the nurse anticipate assessing in a client following a C-section? Select all that apply.
All of it.
A,
A,
B,
B,
C, D,
C,
and E.
B. All of them.
Right, all that apply. Yes. Very good, guys. Okay, how about a few more and then we'll take a little break, okay? Oh my goodness, it's already 4:12. I guess we should. But anyway, emotional care. Having a baby brings about a lot of changes, emotions, physical changes, relationship changes, everybody, right? It impacts the entire family. Okay, so I'm gonna stop here and I'm gonna give you a little break. How about 10 minutes? 10 minutes, and please come back and we'll resume. All righty. Take a little break.
Okay.
Y'all been very good. Thank you.
Thank you.
You're welcome.
Professor Dunham,
I did. Hi, Hen.
I have a question.
Sure.
I don't know if we're gonna go over this like after the lecture, but I can't find what nursing action should be taken to relieve pain from breast engorgement. I'm
Well,
only
I'm going to go over that in
Okay.
the next couple slides.
okay.
But guess what you do? You put ice packs.
Ice packs. Okay.
Yeah, those good old ice packs between your breastfeeding. Yeah, engorgement is never good. You know what else you can put is cabbage leaves too.
Cabbage leaves.
Yeah, it works. I thought you liked that. Yeah, ice packs or cold compresses. They always like the terms cold compresses, but yeah. Okay.
Okay.
You have
Thank
any other
you.
questions about anything else?
Uh,
Because I thought I would hear from you.
I know. I'm sorry. It was my birthday yesterday.
Well,
No,
happy
well,
birthday.
it was on the 12th. I'm sorry, but yeah, it's been a busy
Okay.
So, I just have one more.
Sure.
What type of diet should the nurse teach to a new mother with a 4th-degree episiotomy following a vaginal birth?
All right. Well, we just went over that. She's got so think about it. She's got a 4th-degree episiotomy.
Was that the, because I was wondering that too, was that the high protein,
What do you think? I just went over that high
high
fiber,
protein?
High fiber.
high
Okay.
fiber, and what? Lots of water. High fiber, lots of water. Yep. Keep that stool. You know what you're all doing in the colon? You're keeping it all moving. It's called peristalsis. You're moving on out, think of I'm
Mhm.
moving on out, So I gotta move. I gotta move. What's gonna move me? Fiber and water. It's gonna move it. Okay.
Okay.
You got it. You got another
That was
question?
all for me. No, I think
Okay. Anybody else have any
Wow.
questions about the
for discharge, for
Huh?
discharge, for the discharge teaching plan, wouldn't I teach her to take her vitamins and look out for like postpartum depression?
Okay, all right. Okay, what else would you worry about too?
Um,
I'm thinking about how about
Hygiene.
with the vision? She could have visual disturbances related to
Oh, yeah.
preeclampsia.
yeah.
Okay,
If she starts to have like severe headaches.
yes, yeah.
Okay.
How about what about infection? What do you think? What would she take her temperature, right?
Mhm.
She can monitor her temperature, right? Because we don't want her to get infection. So anything above 100.4 is concerning. What else is concerning? We're going to teach her everything we went over, like in the calves. Remember the pain in her calf? If she starts having that going home, she needs to report it. That's pretty significant of a DVT. Remember, coagulation, it runs high in that first 6 weeks. Okay, it takes at least 6 weeks for that to all settle down.
Okay.
And then of course with the lochia.
She wants to watch out for the amount and the color and the smell.
Right, you got it. Yeah. Anytime you have an incision and it has a foul odor to it, you got a problem. You got an infection. She probably would have a high temperature. Okay,
Got it.
you got it. All righty. Take a 2
That's
minute
all I
break.
have.
Okay.
Thank
Now you got 2 minutes. Oh, no, I think you have more than that. Okay. Anybody else have any other questions?
I do.
I
Okay,
did too, Ms. Dunham, but I can wait.
I was having trouble finding the APGAR score.
the APGAR score. Yeah, let's see. It's right.
That was what my question
Textbook.
was, Ms. Dunham, because I found it, but like it says, it's an evaluation in infant's condition and response.
Where did you find it?
resuscitation.
Chapter
It's in that
6.
chapter 9, the chapter that
Oh my
was due this
God.
week.
It's in
Yeah,
chapter 9.
yeah, the reading of this week.
Okay, because I've just been all through this thing and cannot find it.
Yeah, I believe it
Chapter
was 9.
6 has the stages.
Yeah, and
Chapter-
because we've been over that. Also, guys, in your HESI book,
Chapter 6 and chapter 9.
in your HESI book, it really does a great job on the APGAR score. Let me see if I can find it for you.
No, you know what? It was in chapter 6. I'm sorry, not 9.
Oh
The
yeah,
APGAR score was in chapter
yeah,
6, right under table 6.7. It started going into the notes section of it.
yeah,
In chapter
Sorry
6.
about that.
yeah.
Mhm.
We did chapter 6. Remember that a few weeks ago? Yeah.
Okay, I got to go back
Yeah.
in there then.
If you on your digital
Yeah.
book, put page 158 in and it'll pop it up.
Okay, thank you.
Oh yeah. Okay. Good. Now you are reading the HESI book, right?
Back and forth.
I love it. Who's laughing? I love your laugh. It's good. That's such an honest laugh. I love it.
Yeah.
Oh gosh.
Yeah, I'm getting inside that HESI book.
Yeah, because I tell you what I'm looking for. Let me tell you what I'm looking for on that APGAR score. Let me find in my notes here. Hold on. Well, you know, why we do the APGAR score?
It's said to determine the fetal's condition after resuscitation. When they say
Right.
Yeah.
resuscitation, what are they meaning?
To make
the
sure they
fetal
don't
heart
need
rate
extra
went up?
medical care.
And they, and it's a score that if it's above an eight, what would you do? You do some gentle stimulation. But if it's below, it's like a four, remember we went over this, like a 4, you would do.
Yeah, it said a 4 was gentle stimulation.
No,
Yeah.
no,
It
not
said
a
4 was gentle
No.
stimulation, such as back rubbing, and it
Where
said
they say
that.
that? No, that
It's
4,
on page 158.
okay, that would be
It said
low.
a score of 8 to 10 requires no action other than continued observation in support of
8
the
to
infant's adaptation.
Okay,
A 4 to 7 means the
Oh.
infant needs gentle stimulation such
Yeah.
as
Okay.
rubbing the back.
there you go. Okay, y'all just memorize that. You got a hint? Now, on Friday, I go over all this again with you, but that's a big hint. Because that'll be on exam number 2.
What'd you say would be on exam number 2?
APGAR.
Okay.
Okay, so if I gave you this, kind of question, you're assisting care of a newborn after spontaneous vaginal delivery, and the 1-minute APGAR was 8. What would you do?
Continue observation.
Well, what else am I worried about?
If he's at an 8,
Yeah, all babies I worry about. Thermoregulation.
thermoregulation, yeah.
So what are you gonna do? He's losing body heat because he's
Put him under a
wet,
radiator. I would
because
think
he's
it's-
wet. He's wet. So what are you gonna do? I'm gonna dry the infant.
Mhm.
Dry the infant and place what? And
On
place
the
him in
mom's chest.
yeah,
What is it? Body to body? Skin on skin.
skin to
That's what
skin.
it's called.
Okay, skin to skin. Okay. Okay, we went over that. All right. That's why we do the APGAR, because we want to know how much stimulation and what we have or resuscitation we need to do for the infant. You know, we don't want to do too much if it's not necessary, but if it's low, then we've got to get in there and do some, vigorous stimulation. All right. You got it. Anybody have any other questions? Because we're coming back from our break pretty soon. Oh, we have a visitor. Dr. Brown's with us. Hi, Dr. Brown.
Hello.
We just
When
taken
you,
a 5-minute break.
Actually, you've been on a 10-minute break, and I've been here for.
She sure has. She's been there for a little while.
Okay.
I've
Well,
seen
we're
her.
all coming back. We're all coming back. We're all coming back because we got to finish our little lecture here.
Yeah, I just sneak in and out
I
constantly.
know, that's great. We'd love to have you. Yeah, we're going over some stuff. Right, guys?
Yeah.
Right.
Oh, okay. All right, we back? I think that was a 10-minute break. I gave you a lot of information. Anybody have any questions?
I did. When you had told her, because I read that in the book too, that the leaves can help with the breasts, for the breast engorgement. What are they doing? Is it the properties in it, or is it like?
It's actually the properties in the cabbage itself that helps relieve.
Okay.
Yeah, it's like an enzymatic reaction. And so it actually relieves a lot of the engorge, the relief. But what else works really great too for breast engorgement?
turning your body towards the stream of the water in a shower. It relieves some of that pressure, like that. To me, it did.
Yeah, but
so
not,
it worked for me.
you don't want to stimulate the breast, do you? Is that, could that be
Well, to
stimulating?
relieve some of the milk, it did, huh?
Well, that could actually
Because it said to
stimulate.
pump. Like in the book, it said you can pump. Like
know, but
pump
that
some
actually
to
would
relieve the
stimulate.
engagement.
But yes, why do they say that?
Say which, hold on, I think my thing's going on. What did you say? I'm sorry.
Why do you think they're suggesting all those?
To help relieve that, well, it said if you wanted to continue to breastfeed, you want to relieve the pressure, or if you wanted to stop breastfeeding, you can try and let it engorge so that way to slow down the hypothalamus response and all that stuff.
That's good. You're doing your reading?
There's some good information in here. Just a big
I
chapter.
know, isn't it great? It's a good one. I love it. Okay, we're all back. We need to go. We need to move on because why? We have a lot more to go. All right. We have our thinking caps back on. Yes? Come on.
Yes.
I don't want to be by
Okay.
myself. I never like be by myself. Okay. So we went over the emotional care. That's where we stopped. And so now we got moms and we have dads, right? And remember I said you don't have a special license to be a mom and dad, right? You have to have a license to like drive a car and everything else. But moms, no, we don't. We're given a baby and here we are. But we go over things because there are some psychological changes during the puerperium or postpartum time. So we have phase 1. We have where we're taking in. Now this is mom. So what's she doing? For the first 24 hours, she's like focusing on whom? Who's she focusing on?
The baby.
She's focusing. Now this is mom. This is the psychological changes of mom during the postpartum. She's focusing on the need for food and fluid and sleep. She's been through a lot. She's been through labor, guys. She could have 18 hours of intense labor, right? And so she's tired. I want to sleep. And usually my patients would say, give me a cheeseburger. And they usually have their husbands go down to Burger King and get a cheeseburger with French fries and a milkshake. Okay. Well, they're hungry. So that's phase 1. That's just the first 24 hours. All right. Then we go into phase 2. This is called taking hold, where they're interested in learning and how to care for herself. Now she's getting to be more interested, and now she's going to be more receptive. Say you're going to teach her how to do pericare, right? Well, she's interested now to learn because she has to go home pretty soon to take care of herself. Okay, and you have to, when you do teaching, you have to assess, your learning. If she learning? You could be teaching, but is she learning? And she's not ready to really take everything in. She is going to stay with her? No, it's not going to stay with her. Then you have phase 3, you have letting go. So you accept reality and the baby. Okay, now on day 3, we're going home. And so she really is now into that phase 3. She says, okay, it's me and the baby. Okay. And everything I just was, when the nurse went over the past couple of days with me, I had to take with me to home. So that's why when you do your discharge planning, okay, remember, we always start discharge planning on what? The first day of admission. Because you only really have 2 days for a vaginal delivery to get everything you need to get in, and 3 days for a C-section. All right. And then you got postpartum blues. This is very normal because the extreme hormonal changes that are going on. So she could be what? She could be sad, a little blue, a little sad. But why am I sad? Because why? What would you think?
It said that she could be upset about the appearance of the baby. She didn't get what she wanted. It didn't go the way it wanted to. Like she wanted a natural birth and had a C-section.
You're right. Exactly. Yeah. And plus 2, am I tired? Are you tired after having a baby? Oh yeah. And you can be tired. And then now they go home. And so in the hospital, you had, plenty of help, right? Plenty of help. And if you needed to sleep, you could call the nurse and tell them, would you take the baby for a few hours while you sleep? And so a lot of times we took them to the regular nursery and we watched them there for a little bit. And while mom did have to sleep, but sleep was beautiful and she was better. But when you go home, does she have that luxury? No. Okay. Then you have a little bit more than just sadness. You have what we call postpartum depression. All right. And so now they're not interested in anything. Okay. They're not interested in themselves. They look very, their hair is not done. They're not getting dressed. They're moving around the house. They could be what? The baby too could be neglected. So this
How
is
long
very,
does-
pardon?
I'm sorry, I was gonna ask, how long does postpartum depression last, and can it like progress into like just regular, like full-fledged depression?
Yes, it can. And it lasts usually during the first year. Then when you go beyond that, then we're going into a more serious, this is very serious too, but a longer lasting depression. And then usually they need some help. Because what's the next step? It is the postpartum psychosis. All right. This is where they're hearing voices. And the voices they're not very nice voices, are they? They could be telling her, your baby is from another world. Your baby is a product of, Satan. I mean, there's all kinds of different things. There's been cases. One was in Texas where she actually drowned her babies.
Yeah.
Yeah, you see it on television. It's so sad. And years and years ago, guys, they did what? ECT therapy on postpartum psychosis. Tried to bring them out of it, and it was like electrical shocks to the brain. Very serious. They usually have to get hospitalized for that because they're hearing voices. Now it's called infanticide, and it's called, of course, suicide, but mom will kill the baby and kill herself. So it's very, very serious. Okay. And the big culprit, to all that depression could be really, mom could be just very, very tired when you come down to it, the baby blues. So does she need help during that time? What do you think?
Yes.
Yeah, she needs support.
Yeah, she needs help. She needs support. I always said, y'all come to the hospital when she got lots of help and support. Now, are you all going to come to the home after she gets discharged? And that's what it is. Go to the house instead of going to the hospital, because in the hospital we got lots of things to do too. Okay, now fathers. Okay, we talked about moms. Dads go through the 4 phases of adjustment themselves. They have their own expectations and personal intentions. Oh, yeah. They actually have to now confront reality. Are they daddies? Yeah, they're daddies. They may be, maybe they're frustrated too. A lot of daddies can get a little jealous too, especially if mom's breastfeeding, because the baby's getting what? All the attention. But you can always take care of that. You can always take care of that. You can always take care of, I always tell, yes, mom's going to breastfeed, but you can get up in the middle of the night and go get the baby, change the diaper, and bring the baby nice and clean to mom. Yeah. And then when mom gets done feeding, you convert the baby, change the diaper, and put the baby back to bed. That's working as a team. And so you just have to, go over things like that. And you probably think, well, that's kind of like, that's basic. But a lot of people don't realize that. Okay. And then they have to just they have to see their roles, and they do. And they have to realize there's a lot of rewards being a father. Okay. Then you have your other family members. We talked about siblings before. You have to get them ready, because if you're bringing home a new baby and your little one that's been with you for the past 4 years is now 4 years old, she's been what? She's been the center of your world. And now you're going to bring somebody else, and that needs a lot of care. And so it could be jealousy. So you always want to get them prepared. And at the hospitals, guys, we have we have a lot of fun things to do. We have them dress up as nurses and doctors, and they got babies, and they learn to change diapers. But it's really cute what you can do at the hospital with classes. What are we doing? We're getting them ready. Okay, grandparents. I tell you, grandparents, they also have their roles, and it's wonderful being a grandparent. And usually there is less conflict in the grandparenting, and make sure that, you know, they're coming over, they can take turns. There's lots of things to do when you bring a baby home. Okay, and they can clean the house while mom takes care of the baby. And then we have, on the other hand, if we had a stillborn and if they lost the baby. And the main thing is they have to go through the grief process, folks. So like at Florida Hospital, we had the white rose, and we had the memento box for them, and we had a white rose on the door. That just shows that this woman has lost her baby, and they have to go through the stages. So you have like shock and disbelief, you have anger, you have guilt, they have sadness and depression, and then they have to gradually resolve it. And I think one of your questions on one of the test or quiz was about, you know, what do you do? Well, let them see the baby, ask them. You know, this is all part of, you know, getting to know your patient and wanting to know what they want. You want to find out as you labor them, well, what would you like? Would you like to hold the baby? Yes. Would you like me to take a picture of the baby? Yes. Would you like me to put give you one of the bands from the baby? Yes. You know, and they find out exactly what is available. It's just they have to go through it, and so again, they have to go through the grief process. Just very, very important that they do so, because they have to live with this for the rest of their life. Okay, so we've been talking about parenthood, have we not? Yeah. And so we want to make sure that we get these parents ready so they can have good communication between themselves. They have to work really close now as a team to raise this little guy. And there may be some conflict. There may be some fatigue, and the fatigue always causes irritability, and they may have, you know, they can't go out like they used to. Maybe they used to go out to eat a lot, and now they can't. So this, you know, they feel this loss of freedom. And two, if they're young, remember we talked about that special group, like the teenage pregnancy. Well, that also, them getting used to parenthood is very much so, because now, you know, their friends are doing other things and they can't do it. So you don't want that young mom to take out on the baby. So you have to You have to always make sure that they have support. And there's really good support groups. So when you do a care plan in maternity, you're doing a family care plan, because you're going to not only focus on mom and the baby, but you got mom and the baby, daddy, and then the entire family. So you want to put that into your care plan. And we want, you know, we all want that the family achieves, you know, the goals of, remember the healthy people, and now we got healthy people 2030. I remember it was Healthy People 2000. Okay, so anyway, you want to you know, collaborate. And then here you got some data collection for the family care plan, and this is all things that you would add into. So again, occupation, cultural group, religious, and developmental tasks. And you can see how communication patterns, decision making, you can see how everything kind of goes together as to a family care plan. All righty. Now we're going to go into the baby. And I tell you, baby go through what we called a transition to extrauterine life. Extrauterine just means outside the uterus. And it does, guys, believe me, it takes some time. And the biggest job these babies have is what? What do I always say? What's the biggest job the baby has to do when he's born? How about breathing?
I still I don't want to say it. It sounded simple.
Well, but it is breathing. That's his biggest job, because, you know, they can come out and if mom's had a narcotic late in her labor, which we don't do, and she had not say narcotic during transition, this baby's going to come out. He's not going to be breathing. That's why we do those APGAR scores. Remember, we talked about that during break time, the APGAR score. So we want them to breathe. So we have these 3 phases, and I believe we went over this in chapter 6. Phase 1, you have the period of reactivity. That goes from 0 to 30 minutes after birth. Then you have phase 2, you have decreased responsiveness. I mean, they're tired. Remember, phase 1 we talked about, remember, is in the labor room, and the baby now is bonding with mom, you know, and we dry the baby off, make sure the baby, stays dry and warm. And then after that, they can last up to about a whole hour. And then after that, they get kind of tired. Well, it was a big job, you know, birthing. And so they go to sleep. Well, this is a good time that you can take care of mom during her postpartum time and get her all cleaned up, and baby can go with dad to the nursery. And then they can do their assessment there. And then by the time that's done, that's about now, the baby is now about 2 hours old. Baby goes back to mom on the mother baby unit, and that's phase 3. And then you go through your second period of reactivity, which is 2 to 8 hours after birth. Okay. So this is what I've been talking about, is supporting thermoregulation. So here's the temperature of the term newborn. And right now we're talking about term newborns. So 96.8 to 97.7 is your skin, and axillary is 97.7 to 98.6. So it's the maintenance of body temperature is very important to the newborn. Why do you think supporting body temperature is so important to this baby?
Respiratory distress and
Organs.
Yeah, because the baby is going to try to keep himself warm. If he's probably thinking, okay, nurse, you're not warm here, so I've got to work a little harder to keep myself warm. So I'm going to use all the sugar that I probably have up in my little body, because I got it. I'm working hard, so I'm going to use more sugar. So I get hypoglycemic, and that leads into respiratory distress. All right, so I'm breathing fast. So I got respiratory distress, and I'm using all my sugar to be warm. Do I want to do that? No, I don't want to
No.
be that has hypoglycemic on me. So what are you going to do? What are you going to do?
Skin to skin, put them under the lamp, under a little heat lamp, wrap them in a blanket, maybe.
Put a hat
Put a
on.
hat on his head. Yeah.
Yeah.
Terrific. Yes, exactly. Because a lot of heat goes from the top of the head, right? Yeah. All right. So I'm going to dry him off, remember? And I'm going to put a nice warm blanket on him. And I'm going to put his little hat on. And he's going to say, thank you, nurse. And that's what they're saying, because now they're warm and their body temperature is normal. And so they're not going to get hypothermia on you, and they're not going to get hypoglycemic on you, and they're not going to go into respiratory distress on you. Okay, so you just saved that baby a whole bunch of distress. All right, so this is how I made this slide up for you. This is how heat is lost. And heat is lost by any of the following ways. One, evaporation, which is evaporation of liquids from the skin. So we're going to dry that infant quickly. So dry and cover the head. Another way is called conduction. This is again caused by direct contact with a cold surface. So I want to pre-warm the radiant warmer. Convection is a loss of heat away from the body by a draft. So don't place the crib by a window, because you can get a draft from the window. And you can get, and down here in the South, we have all these air conditioning vents. You don't put a crib under a vent. He's going to lose heat from his body through convection when he's put under something like that. And then radiation is caused by, he's by a near cold surface. So like up north, when the walls actually get cold, because it gets so cold outside, you ever feel your own walls, sometimes you can feel the coolness to it. Well, you don't want to put a crib next to that. And I'm going to wrap the baby up, nice and warm, right? So these are just ways, and in how they come across on on HESI is that they give you like a scenario, and they say, by what ways does the baby lose the heat? And even when you take a baby in for weighing the baby, don't you ever see the nurse put like a little real thin tissue paper down on the scale, again, to keep his little body from touching a cold scale, because he's going to lose body heat. Okay, so that, and then these are ways that I came up with interventions to control your thermoregulation. I just put into a different type of slide for you to see it. But again, it's pretty important to go over that and just to kind of write them down and to learn it. Okay, nursing care of the newborn. Okay, so identifying the infants, remember, they have to have ID bracelets on before leaving the labor room. That's it, guys. You've got to put the bracelets on. Why? Why do you think that's so important?
Security. Making sure the right baby gets to the right mom.
Exactly. Many years ago, that was a big problem. You hear the stories and you can see them on like Netflix and that's the other channel, Hallmark. They have the stories, right, where baby gets mixed up, is because they weren't properly identified. So no matter what condition this baby's at, okay, if the baby is comes out and he's slow to respond, we're still going to put the bracelets on, but there'll be one nurse making the bracelets out, putting the bracelets on, while the other nurse is resuscitating the infant. That baby, all babies have ID bracelets on. So babies have one on the wrist and one on their ankle. And then they have their security band on. And then mom has a bracelet on her, and daddy or her partner, whoever she designates, has his bracelet. Okay. And so we kind of, when we look at newborns, we look at different ways. Now we go more into newborns in a little bit, a couple of weeks, but I just wanted to show you the different things we look at. We look at gestational age evaluation. That's how old the baby is. We look at the skin. If the baby is post dates, he's going to have dry, peely skin. Okay. All right. Because he's been there too long, right? What protects those baby skin? What's that called?
Amniotic.
Vernix.
Vernix
Yeah.
caseosa, right? By the time he gets to be post-term, that vernix has what? It's worn off, right? So he has less and less. We look at the hair on the body. How much hair is on the body? How much hair is on, like, if he's term, he'll have only a little bit. Sometimes you see it on the little shoulders. If he's preterm, he has more hair. If he's post-term, he has what? Less hair. Okay. Sometimes you just see it on the little earlobes or the ear. Okay. And then you're going to look at the breast tissue and the genitalia and the sole creases. Those are just things that we can evaluate very, very quickly when we're looking at the newborn. Like I said, when we go into newborn, we're going to go into more detail. So again, these are things we're going to be looking at as observing bowel and urinary function, security measures, urinary function, right? Make a note of this. Some may not urinate for as long as 24 hours after birth. And sometimes they cannot void for 48. But if that happens, we're not letting that baby go home, of course. Okay. So we want that baby to urinate. And so we teach mom on the mother baby floor to how to mark in case, the nurse is not always in there. but we want to make sure that that baby urinates. And then bowel function. Okay, now, most babies will pass the meconium, which is the first bowel movement, in the first 12 hours. Okay, or at least before we discharge. We want to make sure that that baby has his first bowel movement before leaving the hospital. Because we want to make sure everything's good, right? Everything's functioning.
Would it count if the baby poops like in the middle of pushing out? That wouldn't count. They would still have to have another bowel movement.
No, if it has his meconium in utero, then that's considered he's had his first bowel movement. That means we know that the colon and everything, the stomach, is all working together. But we don't want that baby to have it in utero. Okay, because what happens when you have a meconium baby in delivering is that the head comes out, and before that baby takes his first breath, we're suctioning. We're doing suctioning right there on the perineum, and it's wall suctioning. It's not this little bulb suctioning. It has a big Yankar, and it has actually wall suctioning, and we're suctioning this baby out. Then the baby comes out. We don't stimulate the baby yet, and the baby goes over to the radium warmer. We put the baby on the radium warmer, and we still don't stimulate that baby to cry. The respiratory therapist is in the room. He's putting an ET tube down, and he's deep suctioning to get as much meconium out before the baby takes his first breath. Okay, because when baby takes his first breath, now if he had meconium inside, right, then he's going to aspirate on the meconium, and that's called aspiration meconium syndrome. Meconium aspiration. I heard about it. Meconium aspiration syndrome. So, not good. Baby can get very, very sick from that. Okay, here's your brain teaser. Which security measure will the nurse take when bringing the client's newborn from the nursery to the mom's room?
D.
D.
Did I hear D? D as in dog?
Yeah.
Yep.
Yes.
Yes.
Yes. Okay, good. I'm making sure. Making sure. Good. Yeah, you want to verify the infant's ID band. It matches the mom's ID band. Oh, absolutely. Now, I'm just going to give you a little tidbit. If, say, the infant, when he's born, he has some fluid in his body. So you put the bracelet on just enough to fit the baby, but then he loses this fluid. And so sometimes those bands can come off.
Mm-hmm.
Okay, well, when a band comes off, we have to redo all the bands. And it takes 2 nurses together to do that together as your witness. So you have to do all that over. So when you put bands on the babies, you make sure that it's on good enough that it doesn't cut circulation off, of course not, but when baby does lose some of the fluid that he's been retaining, it's the bands don't come off. Very, very important, those bands. All right. This is just a slide. I want you to just take note to it. Is evaluating the gestational age. And we're going to go over this in newborn. But this is a really good slide to don't put away. All right. And so I kind of went over this already, but we'll go over that more. But this, I talked about all this on that slide previous. And when you're taking care of the newborn, you're going to do vital signs. So you're going to measure every 15, 30-minute intervals at first. Then you go hourly, and then every 4 hours. And then you go every 4 hours to 8 hours until what? Infant is okay. Now you're going to always measure weight. You're going to weighing. So we always weigh the baby right in the labor room. And we're going to measure the length and head circumference and chest circumference. And then umbilical cord, I put in here for you. You start at the base of the cord and gently wipe upward and outward. And then you got some screening tests that we do. And one is for PKU, and we're looking for phenolphthalein. And because if a baby is not able to break down the phenolphthalein, he can retain that, and he retains it, and it causes brain damage. So PKU is a test that's mandatory in all states. Another test that we do also is hearing. All right. I hope I'm not losing you too much. I'm going to go through the next few slides pretty quick, but this is a slide that I want you to print up or take a picture of. These are your normal vital signs. I wrote out this because it's so important. HESI likes to put a lot of questions on the exam. They'll give you the scenario and you have to know if it's normal or not. So we know, the respiratory rate is between 30 to 60 and the heart rate, 110 to 160, you know that because that's what the way it was in utero. You always assess it apically and count for 1 full minute. And the temperature, we already went over the temperature and blood pressure. So in a term infant, because we're talking about term, the systolic is between 65 and 95, okay? And then your diastolic is 30 to 60. And this is all measured in millimeters of mercury. So I just want you to keep that handy. Okay. Now, hypoglycemia. What's hypoglycemia?
Low sugar.
Low sugar. So these are signs of hypoglycemia. So it's a glucose below 45 milligrams per deciliter in a term infant. Now, what are your signs? So your baby comes out and he's got poor muscle tone and he's having a hard time breathing and he's kind of jittery and they have a high-pitched cry. Those are your hypoglycemic babies. So you've got to test the blood sugar. So you're going to do a heel stick, and a great picture of doing a heel stick is in your book on page 229. You always avoid the center of the foot, okay? Because on your book, in your book, you can see where the nerves are. You got the plantar nerves right through the middle of that foot. So you do it on what? On the side, right? You always got to make sure that you never go through the middle of the foot because you got nerves and you got arteries. Now, it's not easy to get those heel sticks all the time because what? You got to maybe warm up the baby's foot a little bit. So these are your risks for neonatal hypoglycemia. And we went over this, but cold stress is one of them. We just went over the thermoregulation. Baby uses too much energy because he's what? Trying to keep warm. Then you have a mom that's a diabetic mom. Okay. So baby's been used to all that sugar, right? Hyperglycemic environment. Now he comes out and what happens? His sugar is taken away. So it's like giving someone like a Snickers bar every day, like 5 or 6 a day. Okay, you would love that. And then all of a sudden you cut them off. What happens to your blood sugar?
It drops.
Yeah, it plummets, it goes down. And so what happens to that kind of person? It gets jittery, irritable, sweating, same thing. Okay, so just kind of, I thought maybe you can remember that way. And then an IUGR baby, intrauterine growth restricted baby, could be hypoglycemic. And moms too that had tocolytics during labor. If we were trying to stop her labor and we gave her terbutaline or we gave her magnesium sulfate, they have a tendency, these babies, to come out and what? Be hypoglycemic. Now, asphyxiated, if they're having trouble breathing, they're going to use a lot of their sugar up to what? To breathe. So therefore, their sugar levels go down. So you can see the different reasons why they would have it. And this is another slide again, signs and symptoms of hypoglycemia in the newborn. We just went over that. So it's just another slide to show you. Okay. So keep those slides pretty handy for when we talk newborn. Okay. All right. We went over bonding, but this is the term. This is the definition. Bonding is a strong emotional tie that forms soon after birth between parents and newborns. Then, so that's right after. Remember we talked about the skin to skin? That's bonding, right? And that's during phase 1 of the newborn phase, right? When he came out from that first 30 minutes to 1 hour, you're bonding in the delivery room. So important. And I'm going to tell you, they bond too in the OR during a C-section. Then you got attachment. Now, attachment is over time. And so as the affection is growing, daily, it increases with interaction. So it's over time. And a mom and dad, they have to learn how to what? Listen to their babies. Does babies give you a certain cry when they're hungry? Yeah.
Yes.
Yeah. How about when they're wet diapers?
Mhm.
Yeah.
Well, these are ways that babies are communicating. And that's when we also go with the parents when before they go home. So they can, be clued in. That's also causes the parents stress. Remember we talked about communication between parents, which is so vital for parenthood, and mom's postpartum blues. They have to learn all this and adapt with the baby. And it takes quite a bit for all these things to occur. Okay, so these are ways that you bond with your baby. So you can call the infant by name. And you can pick up when a mom is not bonding properly with the infant, they don't do these things. They don't even call them by name. You hold the infant in face. That means you're looking right at the face, and baby can what? See the outline of mommy. They can see mommy's face. We talked about skin to skin, and then of course talking in what? Gentle voices. It's always nice. All right, so here you go. Here's another brain teaser. Which of the following dimensions best promotes bonding following delivery?
B.
B. Good. Yeah, if I did any singing to the infant, they probably really cried. Okay, all right. If you're laughing, I know you're listening to me. That's how I can judge. Okay, breastfeeding. Breastfeeding is important. All right. Yes, there's some with the physiology of lactation. You do prolactin. You got two hormones, guys, that are vital to breastfeeding. Remember, one is prolactin and the other one is oxytocin. Now, prolactin causes the production of milk, and that comes from the anterior pituitary. And then you have your oxytocin, which causes the milk what? Ejection, or we call that letdown.
Letdown.
Yeah, exactly. So remember those two hormonal stimulations, please. And then you got the composition of milk. Just know that it's a foremilk. It's the first milk the baby obtains. And then you got the high milk. Now, a lot of times there's colostrum, right? That's the phases of milk production. All right, so you got colostrum. Now, colostrum has great protective antibodies. And it takes a few days for all this to come in, to go from colostrum to transitional to mature milk. All right, but remember, because moms will say to you, they'll say, oh, is my baby getting the nutrition it needs because my milk is so what? Thin, because colostrum is very thin. And yes, they are. And you're feeding your baby enough when he has how many wet diapers?
6 to 8.
Good. Okay. So here's another brain teaser. The nurse is discussing the different phases of milk production with the patient. Which phase of milk production will the nurse refer to when talking about the phase of milk production that contains protective antibodies?
Colostrum.
Colostrum.
Yay. Okay. Moving right along. And here's breastfeeding. A nice picture comes right out of your book. And the main thing I'm going to talk about, as we got to wrap up now, is we're going to help moms breastfeed. So we're going to go over the advantages, the antibodies, promotes what? Bonding, has all things to happen. The sucking stimulates the release of oxytocin for mom's uterus to contract. So these are all so very, very important. And these are different positions. And I love the football hold for C-section moms. And I did highlight it for you, because you probably see that on HESI. And then breastfeeding techniques. Remember to tell mom to wash her hands before breastfeeding, please. And you want to make sure that the baby is put to the breast and has the entire areola in his mouth. If he doesn't do this, the correct grafts, then mom has a what? mom has a sore nipple and cracked nipples. And here's your latch on. And that comes right out of your book. And then also we teach them how to release the suction, because you don't want to just tear the baby off the breast, because that could hurt the nipple. So don't do that. They break the suction. They put their finger to the side and they just break the suction. So I'll let you kind of read that. This is, I asked you about the wet diapers. So how about here? Brain teasing. Which of the following indicates successful breastfeeding is occurring?
A.
A, right. The newborn has 6 to 8 wet diapers a day. All right. I'm going to stop here for, I'm going to give 5 more minutes and then we're going to have to take our quiz. Okay. So which nursing action best provides a postpartum client brain pain relief from breast engorgement? Oh, I like this one.
See,
C, apply between. Cold
Good.
packs in between and heat packs after.
Okay, so apply cold applications between breastfeeding sections, right? All righty. And so you can have like ice cubes, a cold compress between feedings. Okay. Everybody got that? All righty.
Yeah.
Good, good, good. So the rest is on newborn. I'm going to let you see. Let's just jump down to this breast brain teaser. The nurse is caring for a mother who delivered a preterm infant. When instructing the client on pumping her milk, which information will be included?
Pump each breast for 10 minutes.
Okay, you should pump each breast for 10 minutes every
B.
3 hours, right?
Mhm.
Because how often should she breastfeed?
Every 3
every
hours.
2, yeah,
Right,
every
every
2 to 3
2
hours.
minutes. Right, good. Okay, and the rest of the slides go over newborn and freezing of the breast milk there. Don't ever put, you can put the breast milk in, but you have to certain glass bottles. Remember, mom can have what, 500 extra calories. Okay, remember she drinks lots of fluids per day to make more milk. And weaning. Weaning is just emitting, you have to do it slow. So what you want to do is you omit like the daytime feedings first. What do you think? There's no real best time, but what do you think of infant that's used to breastfeeding and now mom's going to wean? Which one would you eliminate first?
The daytime.
Right, the daytime. Which one would I eliminate last?
Night, like you said.
Yeah, night. Yeah, because why? Because it's
Longer.
Be comfortable.
Yeah, it's called comfort nursing. They need that time with their mom. Okay, because maybe mom went back to work. Okay, so the lactation nurse has provided breastfeeding education for a new mom. When discussing weaning, which statement by the mother indicates the need for further teaching?
A. I say
Okay, I'm gonna let you all look that up and let me know, okay? All right.
D, abrupt weaning isn't easier.
I said
Oh.
D too.
A. You right.
all.
I looked at, I answered it as, my bad. It's D.
I love it.
Okay.
Okay, guys, it's 5:08. So if you need to take a 2-minute break, 2 minutes, take a 2-minute break. Put your other thinking cap on now to take a little quiz. And we really got through a lot. And what I'll do is whatever we miss, I'll go over some of this next week when we do newborn. I believe we do newborn next week. Do we not?
I don't know.
Let me look. Let me stay here. I got it here. I
Oh, you
always
got
look at my syllabus.
that.
Like you always look at the syllabus, right? Week 8. Yeah, we're going to preterm and post-term newborns. Yeah, we got 2 chapters next week. No, that's week 7. That's week 8. Oh, week 7's next week. Excuse me. No, that's right. Oh, 221. Oh, nursing. Oh, it's nursing care the woman with complications after birth and the term and newborn. Yeah, I can incorporate some of these. I'll make sure that they're in there. All right, take a little break. Get your little thinking caps on. Please, if you finish the quiz quite fast, that's good. It don't matter. but stay on Zoom till 5:30.
Of course.
Just to let you know, I am doing an exam 2 review on Friday,
Okay. What time?
Yeah, what
2
time?
p.m.
Oh,
Yay.
Oh, good. I got a yay. Hey, I got
I'm
a
in
yay.
class.
oh, because I'll have class. Oh my God.
Class all day.
All right. Well, I think real proud of me. I'm getting real good with YouTube.
Mhm.
All right.
Should we go ahead and take our quiz now?
Yeah, but if you finish, yes, you can start. If you
Okay.
finish, then stay on Zoom till 5:30 for your attendance.
Okay.
Okay? All right.
Mhm.
Go ahead. You can start if you want to. I didn't know if you need to go to the bathroom or anything.
Okay.
Is there any math on this?
Yes, there's always one math. Always,
I
you
gotta
always,
get a piece of paper.
you always bank on that, guys.